aldosterone, right?
Right.
It's an adenoma. So it's either an adenoma, it's unilateral, majority of them are adenomas, unilateral. If it's both, it's usually hyperplasia of the adrenal glands. Where do the adrenal glands sit? On top of the kidneys. Okay. All right. So the findings in PA are low renin. Now, why would that be? Feedback. Don't need bean. Okay. Aldosterone high. Okay, so it's out of regulation. So it's the adrenals are just going to put it out because you've got an independent adenoma that is secreting aldosterone, or you've got a large gland that's just putting out a lot, like you do in a thyroid organ. Blood pressure is high. Why is blood pressure high?
Aldosterone, because it's keeping the salt, which is
Salt and water. So you're increasing volume. Okay. So that will increase peripheral resistance, and blood pressure is going to go up. Fluid overload. So their presentation is blood pressure moderate to severe, resistant to medication. It used to be thought that this was a fairly rare phenomenon. It's thought that probably it accounts for more of our blood pressure than we realize. I mean, not everybody, but probably more than was appreciated. Hypokalemia. So when you see this triad, you see a metabolic acidosis, metabolic alkalosis, low potassium, and elevated blood pressure that you can't get to respond to medicines, think PA, think primary hyperaldosteronism. Your aldosterone to renin ratio is 20 to 40 to 1. Makes sense? You got a lot of aldosterone, you have very little renin. What's renin? Casey, what's renin? We've been through this before. What's renin? Cows.
Sorry.
See, Aggies, cattle. Don't your parents do cattle?
Yes.
Okay. Can you name all the stomach parts of a cow? Cattle?
Yeah.
How many are there? 4 or 5? 4. 4. You know which one the renin is? Which part?
No.
One of the first ones. Okay. All right. Okay, treatment goal is you want to bring the aldosterone levels back to normal and all the problems, the blood pressure, the potassium, back into normal range. So if it stays long enough, if you've got high blood pressure long enough, then you'll get cardiovascular effects. So if you've got high blood pressure, what cardiovascular effect would you expect? So your heart can get too big, enlarged heart. What else could happen? Atherosclerosis. What else could happen? You got volume overload. You got a heart failure. So LVH, heart failure. So you get a left ventricular hypertrophy. Okay. Normalized serum potassium, normalized blood pressure. Treatment is based on type. So if it's unilateral, you take out that adrenal gland. Okay. It's curative. 95% plus people are done, cured. If it's bilateral, you got to treat them with a drug because you can't take out both of them. Okay? So if it's hyperplasia, then guess what? Drug, you don't have to learn new drugs. We've done these before. Aldosterone antagonist, spironolactone, Renin, amelioride. Okay? These all will combat the effects. They usually have long half-lives, so they usually can be dosed once a day, so they're fairly easy drugs to deal with. If you look over on monitoring parameters, since you talked about gynecomastia, one of the more common drugs, Cimetidine is one, it's an old H2 receptor antagonist, and spironolactone. So with these drugs, because you're inhibiting aldosterone, the potassium can go up. If you're using them with drugs that can increase potassium, which might be what? ACE, ARBs. So using those together could, and we will see that in heart failure, didn't we do that? ACE inhibitors are foundational treatment of heart failure. Sometimes we will add on aldosterone for those who don't respond to an ACE antibeta blocker. You see also that they are 3A4 inhibitors. That's the problem with Inspira, is more of its interactions. Okay. So that one's fairly easy. Okay, let's look on page 10, Addison's disease. So here's adrenal insufficiency. In all the years I worked in endo, I never saw Addison's. It's just fairly rare. But it's very significant when it happens because you get a deficiency in all three layers. So cortisol goes down, you have to replace it. Mineralocorticoid production goes down, you have to replace it. You have to liberalize their salts. Androgen production goes down. Women tend to have more of a problem in that area, and so you have to replace. So it's like the pituitary. You got to replace all those things if you lose the function. And so here you're going to have to replace what the cortex puts out. Family education is important because these people are very sensitive to cortisol levels. And they can, under stress, can very rapidly get in trouble. So everybody in the family or those people who live with them or are in close association with them have to know how to inject hydrocortisone. In case, and these people need it on an average of several times a year. They may run into the need for it. So let's talk about glucocorticoid replacement first. So we're replacing the cortisol that they can't make. So you see the variation in cortisol excretion in a day is very wide. This is what makes it very hard to treat and replace. Look at the very bottom of the page. The other problem with cortisol is it has diurnal variation. So it starts about 2 o'clock in the morning and it's increasing until you get up at about 8, falls down, fairly low at night, very low production at the, like from evening meal until that 2 o'clock rise again. So how do we replace that? Well, that becomes a trick. Okay. So we usually will go to hydrocortisone. It's very short acting. The reason it's favored is that it's easy to fine tune it. Dexamethasone is nice because you can give it once a day, but you can't fine tune it. So we start with hydrocortisone. And the other thing about hydrocortisone, it's 100% bioavailable, which means what?
You can use that 100%.
Not affected by the liver. Okay, if it's bioavailable, what does that speak to?
You can use that 100%.
When I ingest a drug, all of it is available to the circulation. So there's no first pass, but there's a lot of drugs that don't undergo first pass that don't get absorbed. Statins, about less than 5% of the drug gets absorbed and into the peripheral circulation. Okay? So this is a boon. This is good because you don't get that variability. Okay? So 100% gets absorbed and the concentrations rise rapidly. Now, why would that be important? I mean, within 30 minutes you can tell you've taken it. Why would that be of help? Okay, so it's spiking in the morning. So we're used to, so these people no longer have spikes. They're not producing it. Okay? So, have you ever taken steroids for a while and then stopped them? Anybody been on steroids for more than about 2 weeks? When you stopped it, how'd you feel?
Terrible.
You feel terrible. The fatigue and weakness is awful, especially if you abruptly stop. So I tell people not to do that. So what happens is they've taken their last dose at 6 o'clock at night and they're waking up at 6 o'clock in the morning. How do you think they feel? They feel like crap. So the good thing about hydrocortisone is it quickly gets absorbed. So we can overcome those adrenal insufficiency symptoms early in the morning with that, or we can give them a longer acting at bedtime to try to overcome those symptoms first thing in the morning. Okay, so the total daily dose is 10 to 12 milligrams per meter squared. What do I do with that? What's milligrams per meter squared?
Body
Anybody work in peds? Okay, so long time ago we talked about dosing drugs based on body surface area. That's what this is. So there are calculators out there that you can plug in your height and weight, and it'll tell you your body surface area. Okay, so this is BSA. So you get a calculator, plug that in, it'll give you the range. There's one on Medscape if you want to check it out. Okay, so short half-life, we're going to have to give it multiple times a day. So if we can get the person to take it 3 times a day, that's what we'll do. Twice a day may be acceptable in some people. So we give 2/3 in the morning, 1/3 at night. We're back to insulin again. So 2/3 of the dose in the morning. That's it if you're doing it twice a day. Look at the next page. If you're going to do a 3-time-a-day regimen, then we'll vary the dose. 10 in the morning, 5 in the afternoon, 2.5 in the evening. Okay? We're trying to replicate normally what would happen. So that's the differences. So hydrocortisone, short-acting, rapid onset, 100% bioavailable, 2 to 3 times a day based on body surface area. Those are the big keys. Disadvantages that are listed under there, it's that waking up in the morning with adrenal insufficiency symptoms. So and you'll see there fatigue, lassitude, mild nausea, headache. Those usually will go away once they've taken the hydrocortisone. The longer acting, so using dexamethasone or prednisone. Prednisone is a prodrug, has to be converted. Takes it a little bit longer. Dexamethasone, very long acting. It's a smoother physiologic effect because you've always got steroid on board. The problem is that it doesn't account for normal variation, and it's harder to fine tune. So it's easy to over-treat people when you're using these drugs. So if you over-treat, they'll get the symptoms of steroid excess that we've talked about. Look at illness on the bottom of page 11. When these folks get ill, you have to teach them, here's the things you need to do. Because if you are under your stress, your cortisol levels go up. So we have a rule of 3 by 3. You increase the dose by 3. So if you're taking 20 milligrams a day, you would take 60, and you do it for 3 days. Okay. So the big key to remember is if illness occurs, and they will teach folks, is always err on the side of being most liberal. Okay? We don't want you to be afraid of it because it's worse. The body will tolerate your excess for a short period of time versus you not having enough. It's kind of like blood sugar. We can tolerate 400s and 500s for days. We may feel like crap, but can we tolerate 40s for very long? Not very long. So it's a similar kind of rule. Next page, emergency precautions. One thing I realized in diabetes I didn't cover, but some people need to wear medical alerts, and there are all different types. I can't remember if I talked to your class about it or not, but medical alert I think is the best of all the programs, but it's also the most expensive. It's good because they take a history. So you can be anywhere. You could be in Leningrad, and and you get sick, and they can call medical alert, and they can tell they've got a history. They got your history, your meds, the problem, the allergy, or the problem that you have, the reason why you use medical alert. The rest of them, something is better than nothing. The biggest thing is avoid ones that look like jewelry. I mean, who wouldn't want to wear this? I mean, it's so pretty, but people, EMS, do I have EMT people? So where do you look for a medical alert?
We were on your neck and on your wrist, but we were also told people are getting tattoos now too.
Yes, people do tattoos, that's true, because they're permanent.
And to look right here for that.
So most of the time they're going to look for a necklace, they're going to look for a bracelet. Okay, in kids, where'd you look for in kids?
I don't remember.
So in children you can get ones that you can do ankle bracelets. You can also do little toe tags, not toe tags, sorry, shoe tags. Well, you pierce everything else. Okay, so they do little toe ring, what do they call them, shoe? They're just shoe tags that they can put on their shoe. Some will also do, did your mother sew your name into your clothes? They don't do that anymore. When I went off camp, I was terrible about putting up stuff. My mother sewed my name into everything. So they do that with Alzheimer's patients sometimes. They will sew into the back of their clothing their name and address, so if they get lost, they can be helped. So a medical alerts, or some type of alert system, and those are the best, around the neck or the wrist for an adult. The other is that they need an injectable glucocorticoid, so they can keep hydrocortisone, they can keep dexamethasones. These are injectables, so we teach the family members how to inject, how to draw it up and inject it. Some situations that are listed there, so if they're if they break something, if they have a blood loss, nausea and vomiting, can't keep their medicines down. Symptoms of adrenal insufficiency, or they're found not responsive. So here is where we say, give them an injection. We'll worry about later if that was the right thing to do or not, or if that's what was needed. So instructed to have a low threshold for injecting. That's the key. So if you were to see someone in primary care that had this, that would be one of the things to ask. Do you carry hydrocortisone with you? Is it always in date? That's another good thing. If they're not, when did you last have to use it? Okay, so that's the cortisol. Questions about that? Okay, the adrenal corticoid, the mineralocorticoid. So here we have to replace aldosterone, and there's only one product on the market that I know of is Florinef. It's listed there at the bottom, Hydrocortisone. So a very small dose here, just a tad, just a touch usually will do it. So it comes as a 0.1 milligram, sometimes even just a half a tablet a day. The other is that we have them liberalize their salt intake, especially more so in the summer than we do in the winter. We avoid drugs that waste salt and get rid of salt, like the diuretics. Let's see, monitoring on the next page, about a third of the way down. So here you're going to look at blood pressure. So they're going to run low. They're going to have postural hypotension if they're not well controlled. So using that serum potassium is going to be important because you're giving them a drug that will get rid of that. So can go low. Their plasma renin activity. Okay. So if this comes down into a better range, if we're in good range, sorry, we're not hyper, if we're hypo, then this ought to settle down. This ought to come back into range. If we give too much, it'll just be like having too much aldosterone. So their blood pressure will go up, they'll retain fluid, and their potassium will go down. Make sense? DHEA, so this is the androgen replacement. In this country, it is a dietary supplement. So what does that mean? Not regulated like a drug is. So it may not have all of what it claims to have in the product. So what I would recommend is if you have to have, if someone has to be on it, usually it's going to be women, is have them stick with the brand. Okay. So there's lots of good, there's reasonable ones over the market. Nature Made, Spring Hill, one of those that is that a store is likely to keep. Okay. The more off-brand you go, the less likely they're going to keep it. Nature Made you can find everywhere. So that would be my recommendation. At least if you are going to titrate it against that, more than likely, lot-to-lot variation is not going to be as great. So here, for women, it is more of a quality of life issue. And so usually small amounts of replacement, 25 to 50 a day, will usually improve their mood. It takes several months, so treat them at least for 6 months. If they do not respond at all at 50, then it's probably not going to work for them. So this is just for women. How do you know if you've given them too much? They'll have androgenic symptoms. If they are also women in their reproductive years and you have them on an oral contraceptive that has androgenic activities, that may be enough to help replace. But if you do both, you'll get lots of androgenic symptoms. So the oily skin, hair on the face, places where you don't want it, acne, sweating, body odor, all of those things would be more common. A lowering voice. Hoarseness, not a hoarseness, but a voice lowering. It can reduce HDL. So if you have women who already have low HDL, or there's a family history of cardiac disease or low HDLs, it will make it go lower. Okay. Questions about those? Okay, pituitary gland disorders. So we're going to go through each of the different ones. And if you've got hypopituitarism, then you're going to replace most of these. Okay, growth hormone excess. So acromegaly. What's giantism? Before puberty. Okay, what's dwarfism? Insufficient. Okay. So we're going to look at insulin-like growth hormone factor 1 or growth hormone serum concentrations, either one. Lots of things affect that growth factor, but it's a very sensitive one for acromegaly. So again, it's surgery if they are is the first choice. If not, if you look down towards the bottom of the page, we use the somatostatin analogs. Again, they're inhibitory. Octreotide's been around forever, so samitostatin is one of the common ones that people have used in the past. The other one is a depot, so it doesn't have to be used as often. It may be favored by some folks. Here again, your normalization is going to be on growth hormone and that insulin growth factor. Be sure you know those, what normalizes them. Side effects, there's lots of somatostatin receptors in the gut. So often people will have gut side effects. So you see those bloating, loose stools, fat malabsorption, abdominal discomfort, nausea. They're all GI. Okay. Usually they'll go away over time. So they're only they're monthly. So that's nice in terms of dosing. One's IM, one is sub-Q. People usually prefer the sub-Q. Okay, so that's one approach. On the next page, we have the dopamine agonists. These have been around forever, probably 50, 60 years. Bromocriptine is one in that group. Bergoline is another one. It is generic only. It's a generic name. This one is not used very often, but it's oral, so people may prefer that instead of having an injection. So that's probably its biggest claim to fame. Dosed once or twice a week, so that would be setting up a schedule so that people are in a routine in terms of taking it. The last is the growth hormone receptor antagonist. We'll talk a lot about these in different diseases. They block the effects on the target tissue, so they're not affecting the brain, they're affecting the different tissues that growth hormone affects. So IGF concentrations will go down, so we're going to try to normalize those. It's a daily sub-Q injection. They're fairly expensive. So I don't know in terms of if you get into with insurance, I'm not sure where the preference would be. You're not going to see them very often, but I don't know if they have to go through specialty
we have
pharmacies.
Several people on the Hyperprolactinemia. We had a lot more than I thought.
On the oral.
Yeah.
I'm wondering if the others have to go through a specialty pharmacy. So some things that are deemed very expensive, or they have high toxicities, or they have high educational needs in terms of administration, those will be regulated through and dispensed through what they call specialty pharmacies, which means those pharmacies are only licensed to do those drugs. They won't go through regular pharmacies. So they may have their own different paperwork or things that you have to fill out, or order forms, or they may have things that they have to follow. So they're good, but they also have some downsides from the provider standpoint. They'll increase your paperwork. Okay, so we talk. So measuring here, we're going to follow the growth factor, and liver is the other problem with them. Okay, next page, growth hormone deficiency. Here we'll use, these are mostly short stature, precocious puberty would fall into this group also, the recombinant growth hormone products. There are a lot of them, at least 10. A lot of kids end up with this secondary to our success with treating childhood cancers. So a lot of leukemias, lymphomas of children, they will end up very short stature. They will not attain. They won't have good growth acceleration. They won't follow a normal growth curve. So one of the things we can do is we can inject them with, we can do growth hormone injections for a number of years. Usually they have to inject every day, most days of the week. I think a lot of them are like 6 out of 7 days a week they have to inject. Some kids quit just because they don't want to do it anymore, because it's years of therapy. And you can continue to give it until their own internal growth just starts to slow down. Most of those kids will not attain their projected height, but they'll get taller than they would. So it goes to just kind of having a, I don't mean socially accepted height, but you're within a normal range of height. You also, for obesity, is also, can be helped with those greater heights. So adverse effects. So here's what gets a lot of them is the injection site pain and having to do that for a long period of time. Insurance companies are real sticklers on these because a lot of people like to use them for off-label. So so sometimes there'll be a lot of paperwork and pre-authorizations to fill out. You'll see under dose administration, continue until a desirable height and growth velocity is decreased to less than 2.5 centimeters a year. How many inches is that? 1. So 2.54 centimeters is 1 inch. So most kids will, until they hit that growth spurt, will do about 2 inches a year, fairly religiously until they get into that. Until they hit puberty. So contraindications, active malignant tumors. We don't want to give it more growth potential. And Prader-Willi, have y'all talked about Prader-Willi? Those kids tend to be short stature. Obesity tends to be a big problem with them, as well as diabetes. They tend to have a lot of metabolic problems associated with them. Hyperprolactinemia. So did you all talk about that? Did they cover that in Pituitary? Okay. So we use bromocriptine. Again, a drug that's been around forever, and it is very effective. And it can bring prolactin levels down into normal range easily. Oral agent, going to follow serum prolactin levels. Use in pregnancy, you'll see that that and the one on the next page, Bergoline, that Dostonex is the Canadian brand name. I don't know why I put that in there, because it just goes by the generic name. This one, they recommend that you not use it during pregnancy, not because of teratogenicity, but only in women who have very large tumors that are growing. The cabergoline is a very long-acting, so some women prefer it to bromocriptine. Their side effects and their actions are they're the same class of drug. Okay, questions about those? All right, let's look at pan-hypopituitarism. So here, you have to replace what they can't make. So ACTH deficiency, you have to give cortisol. So we talked about that. It'd be the same as what we did under the primary adrenal hypoplasia. Thyroid, so we're going to use T4. The biggest problem is you can't use TSH, right? There's no TSH being produced. So you're going to use free T4 as your monitoring. Your weight base is the same, 1.6 to 1.7. LH and FSH. If this happens to a young person, a young adult, then you want to know what is your plan for fertility. Do you care if you can become pregnant or not? So here we have to replace LH and FSH. So looking at males, if it's secondary hypogonadism and they're not interested in fertility, then testosterone replacement is used. If they do want to become fertile or be able to have a child, then you have to replace gonadotropins because LH is going to stimulate spermatogenesis. If it's higher up, if it's with the hypothalamus, then you'll have to use the GnRH agonist. Okay, women. So women who have pituitary disease, not interested in fertility. So here we need to do estrogen progesterone replacement. So we can do it in a number of ways. We like to use ethinyl estradiol because that's what the ovaries produce. We like to give it with a patch because it gets around that first pass metabolism. You have to use progestins, otherwise you set them up at risk for uterine cancer. We usually use them cyclically, so we try to replicate the normal cycle of estrogens and progestins. So they may take higher dose estrogens early on and then take a lower dose, and then we reverse that with the progestins, and then we have a week where they withdraw. I have not seen that they use the cyclical birth control pills, but I'm wondering if it didn't come up when I put this together, but that also might be another way to do it because you've got hormone levels or amounts that are very close to what you produce physiologically. If women wish to become fertile, then you would have to do ovulation induction because you're not making LH. You've got to have LH in order to have a follicle develop and produce an egg. So here you could use something like Clomid. We'll talk about that when we get to next module. If they're growth hormone deficiency, then we can give them recombinant growth hormone. It's not used a lot. And for the insurance companies, you'll see that they must meet two criteria. They have to have a low insulin, like growth factor, and hypopituitarism due to pituitary or hypothalamic changes. So they require some laboratory before they will let you, or before the patient can get it paid through them. Okay. Diabetes insipidus. Very interesting disease. The only place I've ever seen it is in the hospital. And I saw quite a bit then. So you got central and kidney, right? One of the two places. So it's either you can't make ADH or the kidneys won't respond to the ADH you make. Okay? So the biggest thing is that they pee a lot, and they pee at night. So we use that nocturia as the first thing that we target so that people can get a good sleep. So that's our main aim, is we want to decrease their urinary output by increasing their ADH. So desmopressin is the drug of choice. It's an analog of vasopressin, or ADH. The other thing you can do for very mild cases is you can use a low salt, low sodium, low solute diet. Some people may prefer it as to taking drug. The drug isn't hard to take. but it can get into trouble if you overuse it. So for very mild cases, you can do that, or you can use that in combination with the drug. Some people don't want to have to mess with it. They want to be able to eat what they want. So if they won't, then you have to move on to drug. So low solute diet, and you can always add in a thiazide as well. Why would we use a thiazide? What do thiazides do? Hmm? What do thiazides do? Right, well, they're diuretics, but what do they do? Why would we use it in this? Why would we give them a diuretic when they're peeing all the time?
Yeah.
Sodium, what does thiazides do to the kidney? Helps you get rid, well, the way we get rid of water is we make it follow something, so we have it follow sodium. So it increases sodium, getting rid of sodium primarily where do thiazides work? The distal. The what? Okay, distal tubule. All right. So with Desmopressin, which was one of your prescriptions, our aim here is we always target the nighttime urination first. We get that down to normal. And then we see how they're doing during the day, and then we dose them. So if we overdose somebody on this, what would happen to them? They'd what? They'd swell. Okay, so they'd get fluid overload for the most part. So that's the tightrope you will walk. Okay, so it comes as a intranasal formulation. It's usually just one dose, once or twice, in one nostril a day. So hyponatremia is the big problem. Avoided by giving minimal dose. So you're going to follow serum sodiums with these folks fairly often until you get them regulated, and then still on a fairly regular basis every 2 to 4 months. Preventing hyponatremia one is paying attention to symptoms, so the patient can recognize, or those around them that live with them can recognize. If your serum sodium gets too low, your brain will not function. Because as that sodium drops, fluid shifts around where sodium is. So if sodium drops in the bloodstream, where is it else? Well, it's higher in the brain, so what happens is water then moves in. So seizures, common, not thinking, they'll have mental status change. That's probably the best way to put it. And they can get brain injury if it goes too long. So where is that critical point? Where do we start getting into trouble? Serum sodium's below what? Normal is what? 135 to 145. You know where most of these are going to show up. What's serum sodium? Well, 115 certainly. I would say below 120 most people are going to have. Maybe below 125 some people will start showing up. So you don't have to have a lot of drop before they will start to get symptomatic. Nephrogenic. So again, large amounts, 3 liters a day in adults, 2 liters per meter squared in kids. So the ADH resistance can be hereditary, can be lithium, remember lithium, and hypercalcemia in adults. Okay. So drugs to avoid, if they are lithium toxic, that's one thing to remember, because that's a serious toxicity. So drawing a lithium level. And then hypercalcemia, are they able to concentrate? Do they have a concentration defect? Next page, get them off the drug that's causing the trouble, correct the calcium, correct the potassium. Low salt, low protein, diuretic, non-steroidals. Isn't that odd? There's only a couple of indomethacin, which is a really old, probably one of the first non-steroidals, seems to do well, as well as ibuprofen. So not all of them in that class can be used. Why would those have an effect? Why would non-steroidals? What do they do to the kidney? Prostaglandins, okay, prostaglandin regulations on what side of the
Afferent.
Afferent, very good. What's on the other side? Well, that's what ACE inhibitors do. Angiotensin II. Prostaglandins. Take those out, this gets bigger, what happens to GFR goes down. Go back and look at those. If it keeps coming up, you ought to go, I probably should know this, because they're everywhere. All right, I will see you at 1 o'clock then.